Okay, so actually for you guys, it's good evening, everyone. I'm sure that you have heard lots of very, endocrine lectures today since morning with a very deep dive into molecular of all those endocrine organs. So now it's still for adrenal. It's a big endocrine organ and it's a very important one. So I will be talking about the adrenocortical endocrine lesions today. And I tried to make it more simplified version of what the advances are with some of the background knowledge. And I'm sorry, as I couldn't hear you a little bit before this start, those who do not know me, some of you obviously know me. My name is Mamta Gupta. I'm one of the genitourinary and GYN pathologists at Beth Israel Deaconess Medical Center in Boston. So this is a common organ which we receive in our practice. We see a lot of adrenal resections actually on our genitourinary bench. Adrenal gland, as previously known as suprarenal gland, as this diagram shows, is a couple of glands which are located on the upper pole of the both kidneys. Grossly, the adrenal glands are triangular structures, and they just have two portions of this gland are cortex and medulla, and you've already heard about the medulla. That's the center part of the gland, which is brown in color on gross examination, and the outer cortical portion appears tan yellow. Here's something to see about what the layers of the glands are, because they are important. And when we discuss the lesions of the adrenal gland, there are three layers of cells in the cortical region. As you probably all know, that they are called glomerulosa, fasciculata, and reticularis, and they all have one important, hormone function, from mineralocorticoids to glucocorticoids and androgens. So cover a lot of actually hormones, which are very important. I'll skip this slide. This is just a very quick reminder of what these hormones are important for, and you'll see many of our actually daily functions are dependent on this. Why they're important for a surgical pathologist? Because the adrenal glands present to a surgical pathologist with mass lesions or enlarged glands. In autopsy reports, it's reported that up to 5% of our population has some kind of adrenal nodule. And to our clinicians, then how do these lesions present? Again, with the same thing, that depending on what hormone function the mass lesion or the enlarged gland is presenting, that is the presentation is based on. So for example, some of these patients present with hyperaldosteronism, which is the mineralocorticoid aldosterone excess. And these patients, as you will discuss probably in some other lectures later, that the presentation is usually with headache, palpitation, weakness, polydipsia, polyuria, hypokalemia, and increased cardiovascular disease. Similarly, the hypercortisolism presents with the typical features of Cushing's syndrome, and virilism, rather rare presentation of these mass lesions, is just the virilization or feminization of an individual. And it's actually more common in carcinomas, adrenocortical carcinomas, which is itself is a very rare disease, or in the pediatric adrenal tumors. We don't see this presentation in adult patients. And some of these mass lesions actually are incidental findings, which are detected on imaging for some other reasons, or they present with the mass effect. That means these are non-functional lesions. These patients do not have any excess of hormones, and they are just detected either as simply the symptoms of a mass effect or incidental findings. And as you all are familiar with this, I will skip this slide also very quickly, that these excesses of each of these hormones actually have a specific name, like a Conn syndrome, Cushing syndrome, or adrenal virilism, as we just discussed. And the lesions which we are talking here, very briefly, their nomenclature is just adrenocortical hyperplasia, nodules, adenoma, or carcinoma. These are the primary adrenal lesions on which we will be discussing today, because these patients can present with the similar hormones syndrome, but lesions may not be actually located in the adrenal cortex, and that's not the topic of discussion for this talk. So the important diagnostic tests done for these patients are plasma cortisol, aldosterone levels, ACTH levels, and aldosterone to renin ratio, suppression test of different hormones, and adrenal vein sampling. This is an important test, and I will elaborate why this is important for a pathologist to also understand what the adrenal vein sampling lateralization means. This test actually tells a clinician whether lesion is unilateral or bilateral, and which side. The imaging studies are very important. Most of the adrenal cortical lesions are benign, but there are some imaging findings which can point towards the more malignant nature of the lesion. So let's start with the case discussion. The first case is a 30-year-old female presented with a headache, anxiety, attacks, palpitation with feeling of chest compression, no weight changes or realization. So in briefly, we can say that this is more of an hyperaldosterone type presentation, and the examination of this patient revealed hypertension and hypokalemia. And on imaging, a 1.7 centimeter nodule was found on the left side of the adrenal, and a left adrenalectomy was performed. Here you can see a grossly 1.7 centimeter lesion, which is 10 yellow in color. On microscopy, this lesion showed a compressed adrenocortical rim on the periphery and the central large nodule, which on a higher power showed a typical adrenocortical fasciculata layer of cells. So these are packets of cells which are large and vacuolated, but these are fine vacuoles. They resemble the immature fat because these are steroidogenic type of cells. So fasciculata cells have very fine vacuoles, centrally located nucleus, no atypia. So the diagnosis on this case, as most of you know, would be the adrenocortical adenoma. What are these adrenocortical adenomas? These are just the nodular lesions, by definition, more than 10 millimeter in size. So there's a cutoff of, and it's an arbitrary cutoff of 1 centimeter lesions more than 1 centimeters. If they're single or sparse nodules, would be called adrenocortical adenomas. And most of the adrenocortical adenomas present with the hyperaldosteronism, and this, if they're usually unilateral, but if they are bilateral, then they are enriched with the cortical hyperplasia of the background glands and microadenomas. So microadenomas are less than 1 centimeter in size. Cortisol producing adenomas are mostly unilateral and small, and they present with the cortical atrophy of the background gland. These lesions, as I just showed you, can be yellow, orange, or tan in color, and they microscopically show a mixture of different kinds of cells. So here are 3 examples of actually Cushing syndrome related cortical adenomas. And you can see on the very top that this lesion looks very tan in color. Typically cortisol secreting lesions are described as tan dark in color, which can mimic some other lesions in the adrenal. And the other 2 are from orange to yellow in color. Really, there is not a very tight correlation with what the lesion secretes and the gross color of the lesion. This is just an example of a non-functional cortical adenoma. And this is also very tan bright in color. And you can see a small area of hemorrhage, which can also show degenerative changes of different kinds, which I'll show you in a minute. Just the higher power of the same lesion, and what I mean by mix of cells is that typically you will see these fasciculata type large microvacuolated cells, or you can have a mixture of cells where the cells can be, as you can see here, are more clear vacuolated, or in the center, the cells look more eosinophilic and compact and small. And this is just the higher power of the central portion of the eosinophilic cells. Sometimes the cells resemble just the reticulous layer of the adrenal cortex, and they can be very small blue round cells with the scant cytoplasm with intervening vacuolated cells. And sometimes these lesions are very dark in color because of the increased pigment in these glands. As you know that these go through that melanin formation, tyrosine, chain of the pathway is here to produce melanin. So one can see these lesions with those pigments or lipofuscin-rich lesions. Here, just to show you that sometimes the lesions are very eosinophilic. This 10 red lesion, which I just showed you here as a nodule, is very densely eosinophilic, again with some pigment here, but round central nuclei with a small nucleolus, no atypia. These lesions typically can also show endocrine nuclear atypia, what we usually call it, and where you can see small nuclei to very large hyperchromatic nuclei, but they are kind of have a wrinkly appearance. And this is sort of degenerative type of atypia and doesn't suggest any malignancy, but it's a common feature and one should just keep this in mind. And here is a degenerative change one can see in the center, and that's that small nodule red area I showed you on the gross. This is the myelolipomatous change, meaning there is a trilineage hematopoiesis happening in this area. And then, as I said, this picture just shows the cortical atrophy. This is the thickness of the entire adrenal gland here. From this point to this point is less than 2 millimeter. And that happens with the glucocorticoid secreting cortical adenomas. Then what is new about adrenocortical adenomas? Really, there is a lot of advancement from the prior, in past few years, and from prior 4th edition of WHO Fascicle to now 5th edition of WHO Fascicle, which is available online. It's not in prints yet. That we have learned a lot about the molecular or the genetics of these lesions. The adrenocortical adenomas, aldosterone-producing adenomas, are enriched in these mutually exclusive somatic mutations of the following, KC and J5, and these are long names. So I'll skip reading them, but you can see that all these mutations are related to the ion channels expression in the zona glomerulosa, which is the mineralocorticoids. And as this red indicate here, KC and J5 is the most common mutation found in most of the 40% of the aldosterone-producing adenomas, followed by these other calcium channel and chloride channel related mutations. And a subset of these lesions can also have the mutations in Wnt signaling pathway, and which is the beta-catenin or CTNNB1 pathway. And there is some correlation with what the mutation is and how the patient's presentation would be and their age and clinical presentation. As one can see obviously here that this kind of mutation is seen in aldosterone producing adenomas, and it is also most commonly seen in younger females. Whereas the CTNNB mutations are seen in the can also be seen in the non-functional and aldosterone-producing as well as cortisol-producing adenomas, and these patients are older in age. Here on the other category of cortical adenomas, which is a cortisol-producing adenomas, have typically mutations in the protein kinase A pathway of cortisol secretion from zona fasciculata. And among this group, the PRKCA, is the most common mutation seen in these cases. The other mutations as listed here are less common, and these mutations can be seen both in the sporadic form as well as in the hereditary form of adrenocortical lesions. The mutations of the sex steroid producing adenomas are not known yet, and they are, as I mentioned, are rare tumors. Now, moving on to the next case, which is a case of a 54-year-old male who presented with symptoms of abdominal discomfort and weight loss. The imaging revealed 17 by 15 by 12 centimeter heterogeneous lesion in the suprarenal area, suggesting an adrenal origin. Biochemical workup did not reveal any evidence of hyperaldosteronism, hypercortisolism, or excess of androgen. So in brief, we can say that it was a non-functional lesion. Adrenalectomy with nephrectomy was performed for this patient because the lesion was big and was causing mass effect. Here is the growth of this lesion. As you can see, a large lesion with the kidney on the lower portion of this picture. The lesion appears to be in the fat of the perirenal fat, but doesn't include, doesn't invade in the, doesn't appear to actually grossly invade into the renal cortex. Here is another example of an adrenocortical carcinoma. So this larger lesion of the adrenal, which are variegated in appearance, show all this hemorrhage and necrosis and are above 5 centimeter and very heavy, are generally the malignant lesions of the adrenal cortex. And these are called adrenocortical carcinomas. What are adrenocortical carcinomas? It's a simple concept that it's just a malignant counterpart of an adrenal cortical adenoma, which are larger and show lot of atypical features. And we will discuss that very, shortly after few of these slides. So how do these lesions look? These lesions are usually solid or nested, as you can see here. Again, they can show eosinophilic cells. They can show a variety of mixture of cells, but typically are solid and very oncocytic looking. Here you can see the higher power of that, and with mix of a little bit of more vacuolated cells in the intervening areas. And here is a much higher power of those eosinophilic areas. These are large eosinophilic dense cytoplasm, central nuclei with some visible nucleoli here. And then there were some myxoid areas in this lesion. So the background stroma here is very bluish and loose hypocellular myxoid stroma. There were abundant areas of necrosis, as you can see on this picture. And there were mitoses, as one point. I'm not sure if you guys can see my arrow, but here is one mitosis. So the mitotic count on this was increased. And counting the mitotic counts in these lesions is actually a bit of a work. If they are not apparent, one should diligently be counting the mitosis in these large lesions to identify the highly mitotic areas and to come up with an accurate count. And you will see why that is important. So what are these adrenocortical carcinomas? As I just discussed, these are not very common tumors. They are about up to 2 cases per million in US population, but there is increased prevalence of these lesions in the southern Brazil because of higher prevalence of P53 mutation variants in that area. There are lots of genetic syndromes associated with it, with the susceptibility of the various genetic cancer syndromes. The important ones are Life-Romani and Lynch syndromes, and there is a whole list of hereditary syndromes which can show a predilection for adrenocortical carcinomas or even adrenocortical adenomas, including multiple endocrine neoplasia syndromes and others. This lesion, as you can see, are usually large and malignant lesions are the most common cause of death from adrenal neoplasias, because the adrenocortical adenomas and other lesions of the adrenal cortex are benign lesions. They cause a lot of morbidity, but they are not really a cause of death usually in these patients. How one can suspect, obviously, from the mass effect, and if the lesion is functional, then the clue to the malignancy, other than imaging, is also a quick clinical presentation, meaning a rapid onset of Cushing syndrome or virilization and feminization, or a synchronous or co-secreting tumors can show both virilization syndrome and Cushing syndrome. in a small percentage of cases, these are incidental tumors. These are found incidentally, but those would not be as large as the lesion I showed you. Hopefully, they're not missed, until they are so big. But these lesions are more than 4 centimeters, but not really huge lesions, which are detected or imaging done for some other reasons. Weight-wise, these lesions are typically more than 200 grams and more than 5 centimeters. I showed you some of the gross pictures, and that's exactly how they look. Very variegated appearance with necrosis and hemorrhage, and the adjacent tissues in, adipose tissue and the organs can be involved. They can also invade into large veins. As I showed you in the microscopy of that lesion, there can be a mixture of different cell types, but largely solid, broad, trabecular, nested growth of eosinophilic cells with loss of reticulin. So if we did the reticulin stain, that wouldn't show a heavy meshwork of reticulin, and there would be loss of reticulin. We typically don't use this, but I'm just mentioning it here because there are some updates on how this should be used in the new classification, WHO fascicle. And then I kind of covered in that lesion that as there can be mixed areas, there are some subvariants of adrenocortical carcinomas, and they can be oncocytic, myxoid, as I showed you some areas like that, and sarcomatoid adrenocortical carcinoma. Just to keep in mind that something looks sarcomatoid in that region, that could also be an adrenocortical carcinoma. How do we make the diagnosis of malignancy is a complex issue in adrenocortical lesion. And I think we all always have to use a cheat sheet when any of these lesions, malignant lesions actually, or larger adrenocortical lesions present for a surgical pathologist. The reason being that they are not very common lesions. So you're not seeing them every day. So, you have to just make sure that what you remember from your prior reading is still holds true, and it's all features you have applied for the diagnosis. The other reason is that the criteria for malignancy have been worked for a long time, and it's a complex algorithm how we make the diagnosis of these lesions. There are various, scoring system which have been used, and here are the names of those scoring system. I'm sure that you all are familiar with the Weiss scoring criteria, and then a modified Weiss criteria, Lin-Weiss, Bestselia criteria, Helsinki's criteria, reticulin algorithms, which are some of the new ones, and then the Vinke criteria for pediatric adrenal cortical neoplasm. This slide just shows you which criteria to use for what kind of adrenal cortical neoplasm. So the conventional adrenocortical neoplasm, these are the 3 or 4 scoring system one should be using. For oncocytic adrenal cortical neoplasm, the Lin-Weiss and Helsinki criteria scoring system or the reticulin algorithm should be used. And for pediatric tumors, the Vinke criteria should be used. And these are complex criteria. And here is just, these are from the new WHO fascicle, the features which are evaluated and then given a score. But you will see most of these criteria typically use the same features, which is the mitotic count, degree of nuclear atypia, necrosis, capsular vascular invasion, and what kind of cells you are seeing there. And in the reticulin score, of course, the loss, how the if the reticulin framework on reticulin staining looks altered. And each feature is given a number, and then based on what the total score is, the malignancy is decided. And usually you should put, if the features are not like a very high score, one should always describe in their note what features did they see, not just a combined score, rather what features they are seeing, so the reader can see that how the scoring was assigned, like what things made it to a score 4 or 5 or whatever that might be. These are the few other criteria as I just discussed, and in some of them, they might be based not kind of the number, but you have to also remember that at least like in oncocytic adrenocortical tumors, that one has to have there are some major criteria and then some minor criteria. If one major criteria is present, lesion is actually called malignant. But if one minor criteria is present, then one can call it a lesion of uncertain malignant potential. And absence of any major or minor criteria actually decides that one can call the lesion as benign nodule. This is just a chart for the pediatric adrenal tumors, which we as a pathologist for adult adrenocortical tumors, I don't come across the pediatric lesions as much, unless the patient is at a very cutoff age. But you might encounter these lesions at your benches. What is the molecular advancement in the understanding of adrenocortical carcinoma? Like the adrenocortical benign lesions or adenomas, we have learned a lot about the molecular of the carcinoma, carcinomatous lesions of the adrenal cortex, and the two important pathways for adrenocortical carcinomas are Wnt signaling pathway, the same, beta-catenin, CTNNB1 mutations, and these are the mutations, most important ones, and ZenRF3 deletions. So mutations and deletions in the Wnt signaling pathway is what we see mostly in these tumors, and the cell cycle regulation, mutations that will include TP53, RB1, MDM2, CDK4, and CDKN2A mutations. The other classes of mutations which are seen in adrenocortical carcinomas are chromosomal maintenance and chromatin remodeling mutations and amplifications. The mutations of PRKAR1A class, and then the ALDO. But these lesions do not show aldosterone, even when they are aldosterone producing carcinomas. They lack the aldosterone driver mutations, the one we just discussed in the adrenocortical adenomas. There is, a classification, which is the CpG island methylation. Based on that, actually these lesions can be SIMP-high, SIMP-low, or intermediate, and the SIMP-high lesions are associated with high risk, are high-risk lesions, and they show much worse prognosis. What are some of the differentials which you should consider on the gross as well as in microscopy are, one is the pheochromocytoma, which you heard a lot about, I'm sure. They can mimic actually these 10 red adenomas. And if the lesion is larger, as this one was, 6 to 7 centimeter, one would think that it could be an adrenocortical carcinoma. Because these lesions also look, pheochromocytomas can look very ugly, but they are typically very blue, but still with the packeted cells and rich in vasculature, there can be, lymphovascular invasion. So just keep in mind and keep a low threshold of doing the stains and working it up. The metastatic tumors in the adrenal can present as a non-functional adenoma, and this is an example of a large metastasis of carcinoma from the lung. As you can see, a very variegated looking large nodule here with hemorrhage and 10 red and a 10 white appearing lesion. And this is the low power of this lesion, very nodular lesion with the central areas, big areas of necrosis. But when you look at the higher power, there is some similarity. It looks eosinophilic. And as I said, these lesions are not common. Adrenocortical malignant lesions are not common. So, one may be not as experienced to actually look at and think about it immediately. So it's a good idea to keep all these differentials in mind. And you can see here in the central area, a little bit more of the ischematization of these cells. And here is the lymphovascular invasion, which is present. And this is the background adrenocortical gland. One can use the staining profile. Here you can see cytokeratin cocktail, CK7, TTF1, and Nepsin A. All these were positive in this tumor, identifying this as a metastatic tumor here. This is melan A stain and synaptone chromo to identify the background normal adrenal cortex. Metastatic hepatocellular carcinomas can present like that. This is an example of a very eosinophilic looking metastatic hepatocellular carcinoma. This is the background. This longer picture here is the background adrenocortical lesion, adrenal cortex, I should say. And these two stains are the heparin stain and the glutamine synthetase stains, which were strongly positive in the lesion, and the background adrenal cortex is negative. Myelolipomas is another thing which has been added as a new chapter in the new WHO fascicle. And these lesions can be big, usually small as a degenerative change, as I showed you in the prior adenoma, but they can also be big lesions with increase, meaning then their weight is more, their size is more, and they have this variegated tan red appearance. So one would think that it could be an adrenocortical carcinoma. But on microscopy, you can see a lipomatous component and a trilineage hematopoiesis. One can see here megakaryocytes and all other, background hematopoietic cells, immature hematopoietic cells. So myelolipomas can be associated with a very thin rim of adenoma in their periphery. So as I mentioned, some of the hepatocellular carcinoma and the other differentials that obviously you would use the organ-specific, the site of origin organ-specific stains to identify those lesions. But remember, these are some of the important immunostains for the adrenal cortex, that they are positive for cytokeratin, melan A, inhibin, and synaptophysin, but they're not positive for chromogranin. The most important, or the most the stain which I like, is a SF1 stain. It's a nuclear positive stain one can use to actually identify the adrenocortical origin. Then this stain here, CYP11B2, is another name one should remember. Even we don't have it and we are not using it, but this is the major change in the WHO fascicle in the edition 5th. And then these lesions are negative for CD117, 45 microepithelioma factor, S100, chromogranin, Pax8, and CA9. These are all the things which can be in the differential from the organs which are adjacent or can arise in the kidney or the perirenal adipose tissue. TFE3, adrenal cortex can be TFE3 positive. So just remember that TFE3 positivity doesn't always mean a TFE3 positive renal cell carcinoma or translocation associated carcinoma. This is a big change in the WHO fascicle 5th edition, that now we are using the CYP11B positive or immunostain to classify these aldosterone producing nodules in the adrenal. So adrenocortical carcinoma and adenomas are not a problem because we know the clinical picture, but then these are bigger lesions, more than 1 centimeter. One can see them grossly. One can see them by immunohistochemistry and a microscopy, no problem. But then there are smaller nodules, and how do we identify or classify them? Any nodule less than 1 centimeter, which is visible by H&E, and even by gross perhaps, and stains positive for CYP11B. And what is CYP11B2? This is an immunostain for aldosterone synthetase. Positive nodule, you can call it as APN, and any nodule which is not visible on H&E, see the color change here is in yellow, and you only identify it by immunostain, but obviously you got the adrenal because patient was presenting with the hyperaldosteronism. Previously we would call them aldosterone producing cell clusters, but you can call them APM, meaning micronodules. And these are typically 4 to 5 millimeter in size. And then there can be a mixture of APN and APM, and they will stain or will be seen on H&E according to what they are, APN or APM. And we used to call them micronodular hyperplasia, but then you call them, now you will be calling them multiple APN or APM. Then there can be aldosterone producing diffuse hyperplasia, and you will see a rim of positive staining in the adrenal gland. So this is an important advancement, but we don't have that stain here either in our labs, and we will be getting it hopefully soon. And then the other advancement is an adrenocortical nodular disease, which presents as a Cushing disease. This is a very complex slide, and all I would say that adrenocortical aldosterone producing diseases should be classified like the one I showed you. But if there is not a big adrenocortical carcinoma, Cushing, presenting, or adenoma, but the nodules are smaller, then and are bilateral, then you're thinking about the bilateral micronodular adrenocortical disease. And these patients are, young adults or children, and they have specific, mutations associated with it, as the protein kinase A, as we just learned in the cortisol-producing adenomas also, and they can be pigmented or non-pigmented lesions. The pigmented lesions are associated with the Carney's complex, and the isolated non-pigmented lesions are not associated with the Carney's complex. Not all of them, but even in the pigmented nodular disease, but a very significant proportion of that. And they have specific germline variation, germline mutations associated with them. This is a complex one. No need to, memorize it or worry about it unless you come across with a case, and then you can go and use this flow chart to sort of see how to work it out. Bilateral macronodular adrenocortical disease, even I haven't seen a case yet, but it's a disease where the nodules are larger, more than 1 centimeter, and these lesions occur in adults. And the pathogenic germline variants here are ARM-C5, MEN1, fumarate hydratase, and adenomatosis polyposis, colonic syndrome type mutations. So just a few gross examples from my, cases, that this is a microadenoma or a micronodule, less than 1 centimeter, like these are 0.8 to, 0.9 centimeter sort of nodules. And here is this gross picture of that microadenoma, very eosinophilic looking lesion. And this is the gross example of a diffuse micronodular kind of disease. These nodules are not really 1 centimeter or even close to that. These are just very few millimeters looking, nodules. It's a very fine, actually, gross. If you look at these, some are 4 millimeters, some are 3 millimeters, and or even smaller. And this is how a scanner view or a 2x view of the adrenal will look like. These are multiple nodules, as you can draw lines around them. And here are more nodules to show you. Some can be with the clear cells, vacuolated cells of fasciculata type, or they can be very eosinophilic looking. Different nodules can have different cell type showing in them. So that's the understanding of the micronodular disease. That's a very significant advancement, I would say, major change from WHO fascicle 4th to 5th, to understand the micronodular disease and how to classify the aldosterone producing tumors. Then in the new fascicle, they have added few other lesions as a separate chapter. One is the adrenal cyst. And adrenal cyst, as you can see, one example here, are these larger cysts in the adrenal. They can be associated with an adenomatous or a neoplastic lesion, or they can be by themselves. The typically adrenal cyst, so this adrenal lesion shows an intense hemorrhage. So hemorrhage can cause a pseudocyst. So one type of the cyst can be a pseudocyst, or one can have an endothelial type of cyst. This is a cyst lining. You can see a fine endothelial lining sitting on a fibrous sort of cyst wall. And this is CD31 and D240, which shows a positive staining of this lining. So this is an endothelial type of cyst. So you can have a pseudocyst, you can have a endothelial type of cyst, you can have really a mesothelial type cyst, or rarely in endemic areas, you can have a parasitic cyst, echinococcus related parasitic cyst. I think this is all I have as an advancement in the adrenocortical lesions. And I'm not sure because I couldn't keep the track of time, but if there is time, I will be happy to take any questions now.